All right. Um, like Aaron said, I'm Dr. Sandler. I'm a psychologist. I'm up in Fairfield. I am a QME. What I'm talking about today is just the psychology of rehabilitation. I don't know what everyone's level of knowledge is with this. I know some people just got onboarded like yesterday. Some people have been around here for like 15 years. Some people have more interest in the psychosocial aspect of chronic pain than others. But I wanted to go over some really basic topics, and those topics are the psychology of pain perception itself, the psychological factors that lead to chronic pain, the psychological factors that lead to rehabilitation from chronic pain, and that'll be about it. I'm gonna move pretty quickly because I don't want to waste your time. I know you all gotta get to work and all that. And I know that a lot of you know a lot of these things on some level. So I'm not going to do a 101. I'm not going to rehash things that hopefully you already know, at least as physical rehabilitation specialists of various kinds. But I do want to touch on some subjects. So everything I'm talking about here is evidence-based. If you have any question about that, if you want articles to support what I'm talking about, I'm more than happy to send those to you. I will cite some things, but I have many more in my back pocket if you want those, or if you just want to learn more or anything like that. So my goal is really just to enhance the understanding of the complex interplay between the psychosocial and physical aspects of chronic pain, meaning that psychological factors significantly influence pain and outcomes. Hopefully, you already know this, but I want to emphasize that point. I also hope to, in general, increase your grasp of psychological impacts of chronic pain because they're very important. I think physical therapists need to know it. Those of you that were trained more recently tend to get a little more of this than those that were trained a long time ago, especially those who are interested in pain neuroscience. Adrian Liu, or however you pronounce his name, you'll be familiar with a lot of what I'm talking about today. I also want to help integrate psychological insights into practice, including physical therapy practice, things like that. There is a lot of psychology to physical therapy. I don't know if people really understand that. I also just want to start a dialogue, encourage cross-disciplinary discussion. Smiley face, meaning that, I want you guys also to come back to the mental health group and present on your side of things to have cross-disciplinary dialogue about these kinds of things. I have no power to do that. I just have a really loud mouth, but do think it would be cool if one of you guys also came into our group and talked about some similar stuff.
Not to
All right.
stop you, Dr.
Yeah.
Sandler, but it's already in the plan, so I'm happy you
Oh,
mentioned it.
okay. Nice. Nice. Yes. Very good. And by the way, feel free to stop me, but I will just be going really quick because I know it's the morning. I know you got to get to work. So, psychology of pain perception. Point of this is your thoughts, your feelings are physical, right? Many people, including doctors, maintain the belief that thoughts, feelings, beliefs, all those things in your mind, a lot of people just think they're kind of just like floating in space somewhere, right? They're just separate from the body, they're in the mind somewhere. But what really matters is the physical body, our musculoskeletal system, and that kind of thing. So a lot of doctors, even these days, really don't think that the mind matters, so to speak. Even if we believe that our consciousness is separate from the body in some way, I do not want to get into like philosophical dualism versus monism or anything like that. But even if you believe your consciousness is separate from your body, we know that every single thought you have, every single feeling you have has what are called neural correlates. In other words, there are neurons firing in certain ways for every thought you have, for every feeling you have. I'm sure you all know this on some level. So any kind of cognitive activity, any kind of emotional activity, and in fact, any kind of sensory activity, neurons are firing. Right? So even if you believe that consciousness is floating somewhere in the ether, every time there's a change, anytime there's a perception of some kind or another, there is a very physical material process happening in your brain. Another way to say this is that every experience you have correlates with a change in neural activity. There is no thought that you have that does not change your neural activity. There is no feeling that you have. There is no belief that you have that does not change your neural activity. This is what I mean by your thoughts and feelings are physical. At the very least, they have physical correlates and they are causally effective in the physical world. It might seem obvious, but those neurons are physical. They cause other physical things. As we know, once a cause starts, effects cascade. In other words, your thoughts and feelings cause physical changes. We also know that your brain and the rest of your nervous system, your spine, your peripheral nervous system, etc., it's connected directly to every other system in your body. It controls those systems in large part. So, your circulatory system, your respiratory system, your digestive system, your endocrine system, even your musculoskeletal system, your immune system, all these things are affected by your nervous system. Logically speaking, if you think backwards from this, that means your thoughts and feelings can affect your circulation. Your thoughts and your feelings can affect your endocrine system. They can affect your digestion. They can affect your musculoskeletal system. That's pretty important. That means that these are factors that affect all of our physical systems. So basically, what I'm talking about here is transcending Cartesian dualism. If you've ever heard this idea that we are a mind and a body, in fact, we are more than just a mind and a body, right? All our experience is filtered through the exact same nervous system, including everything in your environment. So we're really a mind, a body, and an environment. So everything that we're experiencing through our mind, everything we're experiencing through our environment, including our social environment, that all affects us. This is kind of the reason we have one big reason we have this biopsychosocial paradigm. It's not a bio paradigm, right? It's not a biomedical paradigm. It's not even a biopsycho paradigm, a mind body paradigm. It is a biopsychosocial paradigm, meaning mind, body, and environment all have an effect on all of your systems of your body. Obviously, psychology deals with the psychosocial. The medical field deals with the bio. So the siloing of our fields has made it so we've bifurcated in a way. And only now in the last like 20 years, 30 years, are we kind of coming back together to have a biopsychosocial model, an integrated model, one that is exemplified by the multidisciplinary nature of FRP and just generally the work we do. What is pain? I'm sure you've all heard the IASP definition 500 million times, but it's important that it's defined as a sensory and emotional experience. Pain is not necessarily tied to physical tissue damage. If you don't believe this, then please hit the books, go back to the basics, because this is a really important concept. I'm not going to go into it, but hurt does not equal harm. Tissue damage does not necessarily correlate to the experience of pain. What we know now is the experience of pain is a story that our brain, that our nervous system constructs to interpret signals of danger in our body. You see the image of the brain over there with all the people meeting. That is from the pain neuroscience education type materials, if you recognize that. That story is only very, very partially or a small part, or sometimes even not at all, based on nociceptive signals, the actual pain perception channels in our body. When you look at the pain meeting in our brain, there are those nociceptive signals, but what else is part of them? Your focus and attention, your emotion and your fear, your beliefs, your stress response, your memory, your motivation, your social awareness. All of these things factor into literally how much pain you experience and how you experience that pain. So we know in focus or attention, how much attention should be paid to the threat? How much should I think about this threat? That changes how much pain you experience, and that is a psychological factor. In terms of emotion and fear, how much emotional limbic response does the threat require? How afraid should I be? Again, a psychological response. What do I believe is happening right now? Am I damaged? Has this happened to me before? Stress response, how much of a fight flight response does this threat require? In your memory, have I experienced this before? For example, have I gotten a nail in my foot before? What did that mean? Is this dangerous? What have I done before when this has happened? Memory, again, is a psychological factor. Motivation, how much energy and interest should be devoted to reacting to this threat? And then social awareness, do I have help for this threat? Am I alone? Am I helpless? All of these things happen in an instant in your brain during the pain meeting. And that is something like 8 factors, 7, 8 factors. All of them are psychological factors, and they affect literally the what feels like the physical experience of your pain. So, like I said, most of these aspects are psychological, not based in nociception or biophysical information. They're based in essentially what we consider psychological information. Remember, we know pain is not directly correlated to tissue damage. People can have a lot of pain and no tissue damage. People can have no pain and a lot of tissue damage, or right, the other way around. So we know that many people develop nociplastic pain due to increased nervous system sensitivity, as well as pain pathways strengthening over time. So if we know that pain isn't necessarily tied to tissue damage, if we know that nociplastic pain exists, which isn't all is as well not tied to tissue damage, then we can logically conclude a large part of our experience of pain, if not the vast majority of it, depends actually on psychological and not physiological factors. So the diagnosis of the pain, what actually physically is happening, has almost no correlation to the person's experience of pain with that diagnosis. It's all those psychological factors. Why am I talking about this? I know a lot of you already get this, but mental stuff matters. We get from the physical rehab side, mental health might get the impression that, doing the exercise, that's what matters. That's what really matters in FRP, the physical stuff, right? Because you're building muscle, you're building functionality. Yes, of course, that is primary, but at least with the perception of pain, how much experience of pain you're feeling, how distressing it is, how intolerable or tolerable it is, that is all psychological, essentially. Psychology shapes our pain perception, focus, attention, memory, beliefs, stress, social awareness, coping skills. All these things factor into our experience of pain. This is about the subjective experience of pain that they're experiencing, how they feel it. That's not even mentioning anxiety, depression, trauma, all these other things you guys, I'm sure, associate with the psychology of chronic pain. This is just purely the almost physiological perception of pain that we know essentially a very large part, if not the vast majority, is psychological in contributing to patients' experience of their pain. So hopefully that's somewhat convincing that your thoughts matter, your feelings matter, your beliefs matter in your experience and perception of pain. We also know that there are psychological factors in developing chronic pain. I'm sure you all have seen this diagram before. This is the fear avoidance diagram from, I think, Dennis Turk back in the day. Um, we know a lot about this cycle. We've studied it. It's obviously true on many levels. Um, we get it. So why do people get stuck in it if we understand this cycle so well? There are 3 common mental health issues affecting chronic pain or FRP patients. I'm sure you've noticed this. One is depression, which manifests as low energy, loss of motivation, loss of interest in pleasure and activities, avoidance of socializing, and some other things. There's also anxiety, including increased fear and worry, reinforcing of pain based beliefs that leads to kinesiophobia or fear avoidance, fear of movement, and trauma. And in its more severe form, PTSD, increased hypervigilance, which means increased awareness, increased attention to pain signals, and hypersensitivity of the nervous system. So depression, anxiety, and trauma are common to almost all of our patients. So when you look at this cycle, it seems pretty simple. One thing leads to the next, and we get stuck in that cycle. When we start introducing psychology or psychological variables, or start trying to understand how they impact this cycle, it gets very crowded. It gets very complicated, right? So just anxiety, increased worry. We know that if someone has anxiety, then that exacerbates their pain catastrophizing, their ability or their tendency to catastrophize their pain signals, which means they experience a sensation of pain and they think the worst possible thing. If they have anxiety, that part of the cycle here becomes way more intense. It locks them into this cycle even more. If they have low mood or depression, that is negative affectivity. That's part of what this means in this is your negative affect also plays into increasing pain catastrophizing. We know that the worse you feel, the more you catastrophize your pain. Makes a lot of sense. Trauma, PTSD in particular, the increased hypervigilance from trauma factors into this part of the chronic pain cycle. The more hypervigilant you are, the more fear you have, the more avoidance behaviors you have. So people with PTSD also get locked into the cycle due to that. They also intertwine. These things are never separate. Someone who has anxiety and depression isn't two different people, one with depression, one with anxiety. They're one person, right? So then that PTSD, the hypervigilance leads to avoidance. Avoidance then exacerbates anxiety. Then the anxiety then exacerbates the catastrophizing. The catastrophizing exacerbates the fear and therefore the hypervigilance and so on and so forth. From depression, we also have lack of physical and social activity, right? The disuse in depression in this that filters back into the low mood, which then filters back into the cycle. In other words, this is just some examples of how these psychological issues of depression, anxiety, and trauma factor into the chronic pain cycle and essentially keep people locked into it. So, in terms of what keeps people locked into this cycle, physical pain is only one small little bit. It's really how much they catastrophize that pain, what their pain related fear beliefs are about it, how avoidant they are of pain and pain related behaviors, their increased hypervigilance of their pain sensations, their increased depression and lack of physical and social activity, and so on and so forth. Those are all psychological factors that are keeping them in chronic pain. So your pain experience, it all factors back. Increased pain then makes you feel more hopeless, which factors back into depression. Increased pain also increases fear. The whole point here is it gets really, really messy. Everything is completely intertwined. The fact that this cycle has arrows pointing in one direction is a bit misleading. It's really an interconnected web of chronic pain. So it's not so simple. The chronic pain cycle looks very simple, but people have more than just physical pain. They have these psychological issues that are therefore exacerbating all of these factors of the chronic pain cycle. Luckily, we all, I believe, pretty much work in FRPs, at least partly. In my opinion, FRP is the ideal treatment for literally all of these issues. In terms of depression, there's increased physical activity, which we know is one of the primary ways to deal with depression. We sometimes call behavioral activation or something fancy, and social activity. I'm sure you've all seen that the very fact of having people together, going through the group together, going through graduations, that kind of thing, that social activity helps lift depression. For anxiety, we have in vivo exposure to feared movements to decrease phobic response and to decrease their anticipatory anxiety. So, uh, the physical rehab is, in fact, a psychological treatment for phobias. What you're doing in the gym is an in vivo exposure to something that they're having an anxious response to. Therefore, you're doing kind of a graded exposure to physical activity, especially using their injured body part, and that is literally a exposure and treatment for anxiety related to kinesiophobia in particular. And that's great because usually in clinical psychology, when you're in private practice, you can't do that. You can't just be like, oh, just go to the gym and have a physical therapist do in vivo graded exposure. So this multidisciplinary aspect of FRP, that's one way that we work together to help people that isn't available when we're siloed into our different fields. And then PTSD and trauma, social activity helps. The relaxation techniques help to decrease nervous system arousal. Exposure to feared movements help reduce nervous system sensitivity. The idea being that, again, FRP is an exposure treatment that helps with trauma as well. We know that decreased pain through exercise-induced hypoalgesia or reduced muscle tension or other mechanisms leads to decreased depression and anxiety. So Also, just the kind of exercise-induced hypoalgesia, the endorphins, the reduced muscle tension, all that stuff factors back into their own subjective perception of themselves, of how much distress they're in, how much anxiety they have. When people's pain levels feel more tolerable, they feel a lot less catastrophic about their pain sensations. One reason these FRP patients haven't gotten better previously is their treatment only focused on one of these areas and likely not consistently or intensely enough. So all of these factors maintain each other, right? Pain is maintained by all these factors around it. Anxiety is maintained by all these factors. And if you focus in on one, you could get lucky and kind of break through, but it's more likely that people will start to see progress when we're addressing all of these things simultaneously in a multidisciplinary way, such as in a FRP. In fact, we know that psychological factors are more predictive of chronic pain itself as a diagnosis than physical factors. There is an immense amount of research about this, just hundreds and hundreds of articles about how psychological factors predict chronic pain developing in the first place or getting worse. So it is not the physical diagnosis that predicts whether or not someone will develop chronic pain. Whether they have a certain back injury, neck injury, wrist injury, that does not predict if they will develop chronic pain. So here are some examples that elevated psychosocial factors like fear of movement, fear avoidance, depression, and catastrophizing predict problematic recovery from injuries and development of chronic pain. Other ones focus on self efficacy and general emotional functioning, also as predictors of physical performance and development of chronic pain. We know that psychosocial characteristics early in the recovery process essentially are what determines if someone has delayed recovery, aka chronic pain, or if they essentially have a normal recovery progression. So, psychosocial characteristics specifically are associated with pain outcomes 1 year after surgical fixation for lower extremity fractures. So people hear that, their recovery from surgery is based on psychosocial characteristics, not anything physical in their body. A systematic review highlighted psychosocial factors, including catastrophizing and perceived social support, as significant predictors of pain and dysfunction, often more strongly than physical impairments themselves. So, again, study after study shows that catastrophizing, coping skills, depression, anxiety, lack of social support, those are what predict chronic pain, not anything physical. Fear avoidance belief are highly predictive of work status and chronic pain development in patients with acute work-related low back pain. So we're trying to get people back to work. We're trying to get people to want to work, to feel comfortable being able to work. And part of that is obviously physically getting better. But what is most predictive is their beliefs around fear avoidance. That is what predicts whether they'll go back to work or not. So this is not meant to be comprehensive. This is just dipping my toe in a bunch of different subjects. This is like kind of like the tips, the peaks of the mountaintops. There's this whole base below them if you care to learn about that. Like I said, there's like hundreds actually of articles on that topic in particular of psychosocial factors being the most important predictive qualities for chronic pain. And you have to wonder when you're doing your MDE, when you're doing your evaluation, what is the most important factors you're looking at? Why are you thinking about their pain level as opposed to, say, their PSEQ or TSK, their self-efficacy or their fear avoidance? You have to have a comprehensive understanding of their psychosocial characteristics in order to understand what their possible trajectory is through chronic pain rehabilitation. All right. So I know I'm talking fast, but I just want to get through all this. I don't even know if I will be able to. Feel free to cut me off at any point. But there are psychological factors in rehabilitation, and I want to talk specifically about physical therapy, right? Because not just rehabilitation in general, but there are actually a lot of factors that show the modalities you guys use are very much affected by psychology, which is to say, um, you need to be aware of these factors if you want to be good clinicians. So there are many psychological variables that moderate patient treatment success. I'm just going to talk about three. There are actually a lot. Sometimes these are called common factors as opposed to specific factors. Specific factors being the specific treatment that you are, you know, intervening with in that moment. These are common factors across all treatments, and most of them are psychological in nature. So the patient's motivation, which can be operationalized as the kind of trans theoretical model of stages of change. Patient beliefs, which we can understand as treatment expectations, positive or negative. And the therapeutic relationship with you as a clinician, as a provider for them. So if you guys have never seen this before, pre-contemplation, contemplation, preparation, action, maintenance, I apologize. I'm not going to explain it in depth, but the idea is that the farther to the left you are, the less motivated you are to recover. Pre-contemplation means you're barely even thinking about it yet, right? You're not even considering it. Whereas in action, you're actually proactively taking action, and in maintenance, you are just maintaining all the action you're taking. So the farther left is basically the farther in denial, the farther stuck they are, the farther to the right, the more accepting of their pain, the more proactive they are. So there are different stages of change. It is very helpful to identify where patients are in their stages of change in order to tailor appropriate treatment. If you ever work in drug and alcohol or other fields, you'll see this model all the time because it's very important to know where the patient is at in terms of their own motivation. Something I learned early on is you can't work harder than the patient. You cannot drag someone kicking and screaming to better health. You can lead a horse to water, but you can't force them to drink, et cetera, et cetera. So understanding where they're at means you can tailor the nature of your treatment and approach based on their motivation level. It also means you don't have false expectations of patients and then result in disappointment and frustration. How many of us have had this patient where it's like, yeah, we're recommending for them for FRP, they'll be great. And then they just kind of never really get it. They don't really put any effort into it. They don't get out anything because they're not putting their attention or motivation into the program. That's because unfortunately their stage of change was not, they weren't ready yet. So that first stage, pre-contemplation, means you're not considering active change. These are the patients that are uninterested, they might be resistant, and they're usually focused on passive treatment. I need surgery, even if they weren't recommended surgery. I know that something's wrong in my body and I need surgery. Don't even talk to me about this classes or whatever. God forbid you mention art therapy to them, right? So surgery, doctor, masseuse will fix me. Someone else is going to come. I'm going to lie on a table, hopefully, and do nothing. They're going to come and fix me. Stop talking to me about proactive changes in my life. So these people are not ready for commitment to lifestyle changes taught in FRP. You cannot force people to do FRP. And in fact, in the MTUS guidelines that we all supposedly adhere to, one of the criteria for entering FRP is that the patient is motivated to change. And that makes a lot of sense because the longer you do this, the more you realize if people aren't motivated, they do not go anywhere. We cannot extrinsically motivate people of like rewarding and punishing them into better health. It doesn't work. It's not lasting, at least. So people in pre-contemplation might need to exhaust further care before they realize that it's not leading to lasting relief, right? It's like, what's the process of getting them out of this is very difficult, but sometimes it involves hitting rock bottom, so to speak, of, well, none of that's working. I give up on trying to get the surgery that will fix me. People then go into contemplation where they're like, hey, I'm starting to recognize the need for change, but they're not sure what they want to do or if they want to actually make changes in their lifestyle. This is when you have to discuss the pros and cons of their healthy behavior and their unhealthy behavior. So what you're doing, if you continued that, how would that look for you? What would a healthier life look like for you? Is that something you want? In other words, you have to start to access their intrinsic motivation, their intrinsic values, and leveraging those values toward their better health. Most of our patients are in contemplation or preparation, I would say. So they're usually getting ready to take action, but they don't really know how or what. They feel, a lack of confidence. They feel fear. People in this stage need guidance with clear, structured plans. This is why FRP is great for people in this stage because we impose this routine and structure on them. We give them a treatment plan, we hold them accountable to it, and we try to teach them SMART goals to continue that on beyond our program. So, people who are in this middle stage, you need to focus on what is the structure, what is the plan, and make things as clear as possible. In the action stage, patients actively engage in behavior change. This is, um, I like to call it fourth week magic, which is like in the middle of the program, there's often this kind of fourth week magic where someone's perception changes. There's this sense where like they're resisting or there's inertia. We're like dragging them along for the first 4 weeks, and then somehow something flips and they realize this is helping. I am feeling better. This does work, right? So it feels like momentum starts on its own. That means someone is in the action phase. In this phase, you want to encourage through positive reinforcement. You don't want to be overly helpful, give them too much structure. You want them to start to become independent. You want to correct through feedback that's empathic, right? They want to feel like that you're on their side, and make sure to continue with ever increasing goals. You want to challenge people in this phase because they can get bored or complacent, right? So you want to keep pushing them. And then maintenance is focusing on sustaining new behaviors and the risk of relapse. Relapse in our case is the relapse of all the unhealthy behaviors, the inactivity, the isolation, and so on and so forth. So, maintenance, we need to help offboard patients from FRP with a clear understanding of their home exercise program, of their coping skills, so that they have a plan, so that the end of FRP is not like a cliff they fall off of. It's like an onboard to the rest of their life, right? We need to have that transition and integration. So I talk about this. If this seems interesting to you at all, it's because it's a very helpful way of conceptualizing patients and trying to understand what they need in terms of accessing and increasing their motivation. Our goal should always be to move people like one stage of change farther to the right, one stage of change better, more active, more accepting. So it might help to determine where each of your patients are. You can't force someone from pre-contemplation to action. They have to take steps and it takes time. Like I said, your goal should be to move patients to the next stage. How? Being empathic, being understanding, and accessing their intrinsic motivation. Those of you who have heard of motivational interviewing, which is a psychological technique in theory, know everything I'm talking about right now. You want their own inner motivation and values to guide their behaviors. You want to remind them of why they want to get better. Give clear instructions, celebrate small victories, encourage them to not worry too much about pain. Things like movement is medicine, you are sore but safe. These little phrases that we repeat over and over, they can be helpful of just reminding them and encouraging them along this, and it does increase their motivation. By the way, it should be obvious that patients who have increased motivation have increased positive outcomes with treatment. I didn't put any research up there, but there's a huge amount. It seems very obvious as well. Unmotivated people are not going to get better as much as motivated people. One of the last things I want to talk about is treatment expectations. Patient expectations shape treatment outcomes. Expecting pain will improve or treatment will be effective increases the chances that symptoms will actually improve. This sounds like magic, but it's real. Expecting pain will worsen or expecting treatment will be ineffective actually increases the chances pain will worsen. Our beliefs, our expectations are not just magical things floating around in the air. They are in our brain and they have causal efficacy. They cause other things in our brain, they cause other things in our body. Positive expectations lead to something called the placebo effect, and negative expectations lead to something called the nocebo effect. But I hear you saying, I deliver real interventions, not placebos, not sugar pills. That's not the idea. Pain expectations, the expectations of improvement or not, are present in every single patient interaction and influence, and they influence the outcome of any treatment intervention. So, regardless of what you're doing, if you're doing physical therapy, if you're doing whatever else, it's the patient's expectations that shape the outcomes of that treatment. Cognitive behavioral therapy as well. This is not just physical treatments. Patients who are lower motivation, like we just talked about, are actually more likely to have negative beliefs about recovery. This is one reason why they don't get better. They don't expect to get better. Why would they put effort into something that they don't expect will help them? In 2016, there was a study where patients underwent manual therapy for neck pain. Again, this is manual therapy. This is your guys' stuff. They were categorized into low, medium, and high expectations of treatment success and recovery. High expectations increase the chances of recovery by 47%. So people who simply believed more in this treatment got were 47% more likely to get better. And if you want that link, I can send it to you. That's an actual link on my PowerPoint. I don't know why I linked that, but maybe for ease of showing it to you. But 2009, they studied 5-week CBT interdisciplinary rehab program for patients with chronic pain. They found only patients with positive beliefs about recovery before rehabilitation showed a decrease in pain intensity at the 1-year follow-up. So same thing. In CBT, only people with positive beliefs about recovery when they started had some expectation of help from the program, got benefit from it. In other words, you get out of it what you put into it or what you believe you'll get out of it. This one is kind of crazy. I just wanted to show it to you real quick. In 2011, we studied the effects of a drug based on whether or not you even knew you took the drug. So researchers applied a hot laser to participants and recorded pain levels. So they applied this laser. People said it was a 66 out of 100 or 6.6 out of 10 pain level. Right? So 66 out of 100 is where we start. They were then hooked up to an IV and they said, "You're getting saline. We're just hooking you up to saline. Don't worry about it. Nothing's happening." So they were actually receiving pain medication. And then when they asked their pain rating, it said 55. So they didn't know they're receiving medication, but there was still some pain relief from it. It went from 66 to 55. Someone who's told the IV has medication in it, their pain rating went down to 39. How is that possible? That someone who's aware they're getting pain medications gets, um, you know, 16 points more of pain relief. The only difference here is their understanding and expectation of what that IV is doing. So then they actually say to those same people, "We're taking the medication away. This is now saline." Their pain rating goes back up to 66, but they are still being administered the pain medication. So these people who were aware of being given the medication went down to 39, and then they were told they're not getting it anymore, even though they are, and their pain reverted to baseline to 66. Their beliefs changed their literal perception of pain. This experience shows negative expectations can completely block the effect of an opioid drug more powerful than morphine. Right? Their pain level went back to baseline because they were told they're not getting the drug. It also shows the person believing the treatment was being terminated led to a nocebo effect. That's when it jumped back up to 66. There's a very similar 2007 study that showed telling individuals their morphine had stopped increased their pain reliably, but also not telling individuals their morphine had stopped meant their pain intensity remained low for longer. So you can see in this diagram, one group with the black dots knows they're not getting medication anymore, whereas this other group does not know they're not getting medication anymore. You can see it starts to creep up. Their pain level goes up. Purely the only difference is they believe they're not receiving the medication anymore versus the other group who believes they are. That's a pretty big difference, a very significant difference in pain perception purely based on belief. How is this possible? Beliefs are things. Beliefs, thoughts, and feelings all have neural correlates that affect the rest of our brain, our nervous system, and body. They are part of the pain meeting in the brain. The effect of expectations actually begins in the prefrontal cortex, which communicates with these lower brain regions, the hypothalamus, the periaqueductal gray, the rostroventral medulla, etc. The brain region sends signals down the spinal cord that amplify and inhibit pain-related nerve activity. Those of you who know gate control theory know exactly what I'm talking about. So our beliefs are actually part of that gate control mechanism, one of the top-down things that are sent down our spine that modulate our experience of pain itself. How are expectations formed? By prior experience. like, oh, that hurt me before, so I don't think it'll help me again. They're based on instructional learning, like what they've heard from doctors or maybe even commercials or clinicians. So it's like, oh, I heard about FRP and they said it was going to work great. That is a positive treatment expectation from instructional learning. Or my friend went through FRP, it helped them again. And social observation. I saw that my cousin looked great after FRP. I want that, right? My cousin looked like $1 million after her aquatic therapy sessions. That creates positive treatment expectations. And it's based on the relationship to the source and context. So this is why trusted family members have such influence on people's treatment expectations, right? Oh, my cousin's brother's uncle went to chiropractic once and he hated it. So I'm never gonna go. Negative treatment expectations. So in past experiences, in FRP, we deal with individuals who inherently had negative experiences with prior therapies as they have inherently not led to a significant or lasting relief by definition. Otherwise, they should not be in FRP. Right? All these people have tried things and they haven't worked. They therefore have low expectations of hope for change. For these reasons, it's important to consider what factors individually in a group and structurally in the program affect treatment expectations. What do we do that give patients a negative or positive treatment expectation for FRP? Feeling welcomed when they enter. This seems very simple and subtle. When someone enters and the front desk goes like, "Ugh, like you again? Like, what's your name? Okay, like go to the gym. Bye." They don't feel good, right? Or if someone walks in, there's a smile. Hey, good to see you again. I got you. Like, welcome. That actually affects people's expectations of treatment. This place doesn't want me here. I'm not going to get better. Or this place, I belong here, and this is where I'm supposed to be. A clean establishment, good equipment. This affects expectations. They actually mentioned this in our surveys. The facility has great equipment. The facility has, terrible equipment. It's dirty, that kind of thing. The appearance of unity from providers. Patients try to split us. Oh, mommy said one thing, daddy says another. Or PT said I could do that. The site lead said I couldn't. We need to all be on the same page philosophically as well about the nature of pain and pain perception and recovery from pain. Right? You don't want a doctor saying you should rest and then you're here saying you should exercise. You want a sense of hope for recovery from providers, meaning that you yourself need to express hope in subtle ways. You expect them to get better. If you don't expect someone to get better, they pick up on that. They know. We know this from studies of education and teaching that when teachers have low expectations of students, the students fail. A clear, structured schedule with purpose. Patients love knowing why they're doing something and what they're doing. So having that schedule that repeats, that's consistent, the patients know what to expect and they know why those things are there. Establishing expertise of providers. Many of you are doctors. You might as well use that to show your expertise. Your appearance, right? You don't want to look too disheveled. You want to look professional. You want to demonstrate knowledge and unity of language. You're all saying the same stuff. Movement is medicine, for example. You're all saying the same language. People will not want to take your advice if they do not see you as an expert. And then most importantly is relating empathically and encouragingly to patients. This is a section I'm not going to get to because I'm at the end of my time, but the therapeutic relationship between you and your patient is of utmost importance. In fact, if you do not have a good relationship with your patients, they don't think you're empathic toward them, that you're trying to understand them, that you feel their pain to some extent, or that you respect it, they're not going to listen to you. They're not going to adhere to your recommendations, and they're certainly not going to be enthusiastic about doing exercises at home or anything like that. The other thing is that our group activities in FRP, the fact that they're in a group matters. It's part of the structure of the program that these patients see each other and are encouraged by each other. So doing lifting together, walks together, that kind of thing fosters a positive group dynamic. Having a rolling admission also helps because the more senior patients tend to tell the more junior patients, hey, this has worked for me. I know it sucks the first few weeks, but it does work. And then graduations are a ritual, an important ritual that we do that demonstrates the success of patients to more junior patients. It shows community, it shows collaboration, it shows that you're not alone, shows that we support you, and it's just kind of like a good, for lack of a better word, propaganda, a good message, a positive message that shows that FRP works, and that other people should be encouraged to put everything, their all into it. So I'm going to stop there because I know that you guys have to go. But I just want to say, if any of these topics you find interesting, this is like the very, very tippity top of all of these topics. I would love to come back if you would have me. I'm sure, not next month, but a while from now, whenever you have time. But any of these subjects, I could probably talk for 2 hours on any of them if you really wanted. But most importantly, I want you guys also to talk with me, talk with the mental health team, and share your perspective as well. So I know I've been talking for about 50 minutes straight. Don't have much time for anything, but appreciate you guys listening to this. Hopefully, some of that at least sparked some interesting thoughts. And feel free to send me a message if you have any questions or you want any sources or anything like that. So thank you for having me.